Hello, class, and welcome to the lecture. My name is Dr. Lee, and in this series, we're talking about the pharmacology and toxicity of antineoplastic agents. You're listening to part 3 in the series. We're talking specifically about the targeted therapies for cancer. And with targeted therapies, what we're really talking about again is the targeting of specific proteins or enzymes that are involved in cell proliferation, transcription factor activation, survival, mediators of invasion and metastasis, and mediators of angiogenesis. So this pathway right here, all the way getting down to the nucleus. And so what's happening here is that typically you have some sort of ligand, either epidermal growth factor or platelet-derived growth factor or anything of the such that binds to this extracellular or transmembrane receptor, which then causes some sort of autophosphorylation here and through a tyrosine kinase, and be mindful of that, which then again causes downstream signaling through a whole host of pathways here, which ultimately gets you into that cell proliferation, transcription factor activation, survival, invasion, metastasis, and angiogenesis. All sorts of things that we don't want to happen with tumor cells. So what's actually happened is a whole series of drugs have been designed to inhibit these. So you have things like tyrosine kinases that will bind right to this spot right here where you have the TKMP. It'll block that phosphorylation right there, essentially halting the whole process and stopping this pathway from happening, where you don't get that signal to have that cell proliferation and all those other subsequent consequences. You also have small molecule drugs that are specifically targeted against these different proteins intracellularly, like for RAS or RAF or MEK. We have mTOR inhibitors or AKT-P10, PIK3 we have as well. We also have inhibitors to CDK and PARP, and all of these lots of these different enzymes listed intracellularly. We also have lots of, again, tyrosine kinase inhibitors that are specific to tyrosine kinases for these transmembrane receptors. So platelet-derived growth factor, EGFR, KIT, ABL. We don't have, ALK is here as well, and MET is here as well. So lots of tyrosine kinases that will inhibit again, this part of the tyrosine kinase protein, more on the intracellular side. We've also developed target therapies in the form of monoclonal antibodies, so they will sit on top. They're not small enough to go intracellularly, so they would be the extracellular targets here. So we have monoclonal antibodies derived against things like EGFR, ERBB2, which is HER2. We have monoclonal antibodies for platelet-derived growth factors. Other ones would be things like CD20, all sorts of extracellular receptors. And they would either neutralize the protein and kind of prevent that from happening, or they could bind to the ligand itself and prevent the ligand from binding to the receptor. One protein actually here that's missing that is really important is VEGF, vascular endothelial growth factor. So you can add that to the list as well. So we have multiple ways of inhibiting and shutting down this pathway here. Again, either through small molecules binding to specifically tyrosine kinase inhibitors that bind right here to this type of protein. And again, this type of protein here could be any of these, but it binds to the tyrosine kinase portion of that protein. You could also have the small molecules that bind to all these other receptors that are listed here, or not receptors, but proteins that are listed here. So with these small molecule drugs, I try to find some commonalities in the toxicities. There's not many, but there are some commonalities, and one of those is that just about every single one of them has some sort of drug-drug interaction, specifically with 3A4, but not necessarily only 3A4. So we're talking about drug-drug interactions being a huge issue with these small molecule drugs, especially with the tyrosine kinases. Lots of them have drug-food interactions, a lot of them should be taken on an empty stomach. Not all of them, but a lot of them should be taken on an empty stomach. And so we have to be careful about drug-food interactions and making sure that we're recommending the correct administration with the product. A lot of these will cause QT prolongation. Again, not all of them, but a lot of them will. Diarrhea seems to be a recurring theme with a lot of these drugs as well, and also an increase in liver function tests is common throughout this class of medications. And also, you have to know that there are some of these small molecule drugs that will inhibit multiple kinases. So some of them inhibit both RAS and RAF, plus perhaps EGFR and KIT and platelet-derived growth factor. They're what we call very dirty molecules in that they target lots and lots of different proteins. So I guess in the ID world, we would call that broad spectrum. And it's important to note that these receptors here, these proteins, they're not just causing this to happen in tumor cells. There's regular functions of that protein within normal tumor cells. So the more kinases you inhibit, the more on-target toxicities you're going to get with that. And we see that as a common theme for these multi-kinase inhibitors. So with monoclonal antibodies, a lot of these drugs will have infusion-related reactions, and this is more problematic for your monoclonal antibodies that are more chimeric in nature versus fully human in nature. And in terms of toxicities, we're talking about more related to the mechanism of action. So for example, if you're talking about a monoclonal antibody that inhibits EGFR, you're going to see EGFR-specific toxicities like an acne-like rash, those sorts of things. With some of these, you get severe infections, opportunistic infections, so you have to watch out for that. So as we drill down specifically into these products here, we can broadly classify them according to where they are in terms of inhibiting this whole process. So we have our drugs that work either on the TKI side over here, on these proteins on the cell surface, the transmembrane proteins. So your small molecules would work here. These are your TKIs or tyrosine kinase inhibitors, or you would also have your monoclonal antibodies that would either bind to the ligand here, or it would bind specifically to the receptor itself. And so those would be the drugs that would target the extracellular or transmembrane targets. And then we have those that would be on the intracellular side, so things that would target things like RAS, RAF, MEK, ERK, mTOR is another one, JAK-STAT, BTK, CDK, those sorts of products. So if we look at just the transmembrane receptors, really the big ones to remember at this point in time, EGFR is huge. EGFR and HER2 are related, so this is EGFR1, we could call that, or HER1 as well. So those are other names for that. They're all related, and these small molecules, you can see that they all end in tinib, which means that they are tyrosine kinase inhibitors. All right, so anything that was a TKI would end in tinib. So with these tinibs or tyrosine kinase inhibitors, you're talking about diarrhea being quite common across the EGFR1 inhibitors. So that's both EGFR1 and EGFR2 or HER2. So we can also do EGFR2. And also for EGFR1, acne-like rash is pretty common with that as well. And pneumonitis can happen with these agents as well. So we do have monoclonal antibodies that target EGFR1 and HER2. So things like cetuximab would be for EGFR1. You would see similar types of reactions like with the acne-like rash and diarrhea, but you would have infusion-related reactions as well. Trastuzumab is probably the most well-known monoclonal antibody here, and targets specifically HER2, and specifically is related to heart failure and has that specific side effect. When we get into targeting VEGF, here's another one that we really need to pay attention to. This is vascular endothelial growth factor. This is involved in angiogenesis. So any type of inhibition to this would mean that we have cardiovascular toxicities such as hypertension, delayed wound healing, thrombosis, bleeding, and GI perforation. Those are all issues with our vascular endothelial growth factor inhibitors. So we have their small molecule inhibitors, and again, these would be your tinibs. This is labeled as an anib because an anib is technically an angiogenesis inhibitor, but pazopanib is a TKI. They could have labeled it as a tinib as well, but they chose not to. So these, again, small molecules would inhibit the tyrosine kinase portion of the vascular endothelial growth factor receptor, which would be another portion right there. So those are the highlights of these that I want to go over. There's some other ones that you can read there. They're very specific to tumor types, and just for time's sake, I won't go over them right now. Now, the key point here is that as we talk about the EGFR inhibitors and ALK inhibitors, which is also related to lung cancer, these two would be for lung cancer, really related to lung cancer. There have been we've identified many mutations within the EGFR protein. So within certain types of lung cancers, we get the formation of what we call a mutant EGFR, which is what we call a driver mutation, which actually causes this process to be continually on in absence of a ligand, and so you kind of have all of this cell proliferation and increased survival that's going on, that's constantly being stimulated, and so this mutation can actually have depending on what mutation you have for EGFR, can actually confer resistance to some TKIs. So you have your first generation TKIs like erlotinib and gefitinib, which actually aren't so good at targeting some specific mutations to EGFR1 versus things like afatinib, osimertinib. Those would actually target more a wider range of mutations that erlotinib and gefitinib wouldn't target. So the key point here is that the medicinal chemistry of these small molecule drugs that inhibit tyrosine kinase it differs slightly, such that the binding and affinity in the presence of specific mutations will be stronger or weaker, and thus, we can kind of think about using different drugs to treat patients with specific driver mutations within a particular class. So again, you can have many different driver mutations of EGFR that would require treatment with different drugs. So we'll get into that as we talk about the specific disease states. And a hallmark of that would be something like BCR-ABL for CML, chronic myelogenous leukemia. Now we're getting into the signal transduction part, which is the intracellular component now. There's been many identified mutations of BCR-ABL that have sensitivity from bosutinib and ponatinib and kind of more the second generation TKIs versus imatinib. Imatinib is our first generation TKI, and your subsequent generation TKIs will have activity against different mutations. So the general toxicities here with BCR-ABL would be things like neutropenia and QT prolongation for some of the products as well. Another class of medications that's important would be our RAS-RAF inhibitors. So we can tell that these are RAS-RAF inhibitors by the name. RAF is in here, so RAF, right? So these are actually rafenibs. All of them are rafenibs, and so you can tell that those are RAS-RAF inhibitors. These cause some significant toxicities like arthralgias and fatigue. People complain a lot about that with these. Increased LFTs and QT prolongation seems to be an issue with some of these as well. We also have things like mTOR inhibitors, which can cause aphthous ulcers. We actually use mTOR inhibitors for transplant rejection, so solid organ transplant rejection, and you see the same thing with aphthous ulcers. And the other class here, not to say that the other ones are not important, but the more important class here in terms of for breast cancer and high utilization would be your CDK4/6 inhibitors, which are a new class of medications. So this would be the receptor right here, which is actually involved in cell cycle checkpoints. So if we can actually rotate all the way back up here, it's involved with these checkpoints and progression from one checkpoint to a next within the cell cycle. And so with these CDK4/6 inhibitors, they can cause some significant neutropenia and diarrhea as well. So those would be your important receptors to think about on the intracellular side. And again, there are no MABs here because MABs will not distribute into the intracellular space. So with that, that's the end of the targeted therapy section of this talk. If you like the video here, feel free to go ahead and give a like. Give me some comments on what you liked or what was unclear within this lecture, and hopefully I'll respond. And as always, feel free to subscribe. And if you have any questions, you know where to reach me. And that's it for this video, and I'll see you in the next one.